Good morning. The webinar will begin in 2 minutes. The webinar will begin in 2 minutes. Thank you. Good morning. The webinar will begin now. Thank you.
Good morning, everyone, and thank you for joining. I see we have many folks have signed on. I'm Dwight Hanna, Director of Human Resources, for those of you who don't know me, and my task is to welcome everyone to this meeting. The Human Resources Department recognizes the importance of health insurance to employees, retirees, applicants, and the county as an employer. And the county currently makes a significant annual investment in health insurance, and that's one of the things that we're going to be talking to you about. At one of our impact meetings, Administrator Brown mentioned, I think it was the first meeting, that the current amount that we pay or invest in health insurance is just not a sustainable amount. So that's one of the things that we'll be talking about in more detail later. And having said that, I would like to, I guess, both recognize Mr. Brown. He will be speaking later, but recognize him for making a decision. I think it was last year we were having a meeting regarding health insurance and the cost, and there was an option that would save the county about $10 million. And instead of implementing that option, and Mr. Brown was trying to balance the budget, so it was an option that from a financial aspect that was needed. But instead of implementing that option at that time, Mr. Brown made the decision, which I appreciate. And the reason that y'all are here today, we're here, is that he wanted to get input from employees, retirees, and also form a committee, which we've called the Impact Committee, to get input from them. So I think as we go through this presentation and listen and hear about it, I think it would be important to keep in mind that that's a decision that he made that gives all of you that are on the call and that we'll be talking to an opportunity to ask questions, have input. And I think that's a great thing. I've probably worked in my 30 years in local government for about 12 county administrators now, and I can say for sure all of them, if not most of them, would not have taken this approach. So I certainly appreciate Mr. Brown being interested in engaging employees, hearing their input before making decisions. What the Human Resources Department has been tasked with is providing information to hopefully educate, inform employees and retirees, which is part of what we'll be doing today, but also in terms of getting input from you. There is a lot of information and there's a lot of complexity to health insurance. We had about 7 meetings with the I.M.P.A.C.T committee. Those meetings lasted about 2 hours each. So that's like about 14 hours of information. Obviously, there's no way possible to get 14 hours of information into this one presentation. However, all of that information is on our internet. If you like to view it, there are videos, there's the presentations that were made, there are the comments from the I.M.P.A.C.T committee, there are comments if they disagree with things, there are comments if they suggested things. So we're completely transparent. All the information is there. It's just not reasonably possible to present 14 hours of information in one presentation. It's also important to keep in mind that Richland County has a very rich health plan. This is not my opinion. We've been with Carolina Care Plan, we've been with Coventry, Aetna, Blue Cross, Cigna, and all of them have told us over the years that our plan is better than the plan they have for their own employees. So that's not my opinion or, just something that we're saying. I don't say that to say that's a bad thing, but I think it's an important thing to keep in mind in the context of the conversation that we'll be having. Also, many of our employees have employees and retirees have chronic illnesses, which drives the majority of our claims. Again, I'm not making that as a criticism for anybody that has a chronic illness, just to give you some factual information. Over the years we've been with Cigna, I think right now they're at a cumulative total of around about $9 million in terms of claims they've paid out that exceed the premiums that we paid. Now, from the county's perspective, that's a good thing. From Cigna's perspective, that's probably not a good thing. The way that they view it. Basically, our health claims are paid in by three different sources: employee premiums, county premiums, and the amount that employees, dependents pay out of pocket, co-pays, deductibles, things like that. When you go to the doctor. Currently, the county has employee health insurance with Cigna for early retirees. Those retirees that are less than 65, they're with Cigna, and for Medicare Advantage eligible retirees, that's generally 65 and older, all with a disability. They're with Humana. The presentation that you're going to hear today is a joint presentation by HR and administration. Ms. Lori Thomas will be coming on later to present some. And I think after that, I think Mr. Brown, Administrator Brown, will be. In ending up my comments, I would like to thank the I.M.P.A.C.T committee for the 7 meetings or so that many of them attended. The tough questions they asked, I think the employees would be proud. They were very engaged. They asked tough questions. They made tough comments. So I assure you, they provided their input very candidly. Also like to thank IT and especially Ms. Angela Weathersby for helping us with this presentation. Normally we do things in person, but because of COVID, we're doing it this way. Again, I want to go back and thank Mr. Brown again for providing us this platform for employees to have input at the front side of the process and not on the back side of the process after a decision has already been made and implemented. I think whether you agree or disagree with whatever we talk about today or whatever is decided, I think it's extremely commendable for Mr. Brown to not only permit, but promote a process to where employees, retirees, and everyone have an opportunity to say, ask questions, which you will do, have an opportunity to do today. So thanks everyone for being here, and we look forward to presenting this information and hearing from you later in the presentation. Thank you.
Good morning, everyone. My name is Trina Lomax Walker, and I am also a HR team member, and I will be sharing with you information that was provided to give you some type of background or groundwork to work from as we have this conversation on today. We do want to remind everyone that this meeting is being recorded and it will be available on the intranet for all employees to view. As with everything, the purpose of this meeting is so that we can hear your voice. So we're going to ask that if you could please allow us to present the information that we have prepared and then allow for questions and comments at the end, because of course the purpose of this meeting is for us to hear your voice. And so we're going to try to get through the presentation and then allow that space for you all to ask your question and share your comments. All right, so as I said before, thank you, Mr. Hanna, for the welcome. We will present the information we have prepared and then allow for your questions and comments, and then we will conclude the meeting. All right, so as Mr. Hanna alluded to, the Project I.M.P.A.C.T started with us creating a committee that consisted of employees and retirees, partnered with the department directors and elected and appointed officials to help us identify employees to serve on this committee. To ensure that we heard the voice of retirees, we also sent information out to retirees that allowed them to sign up to be a part of the committee as well. The committee consisted of 25 active employees, 18 retirees, and this consisted of 18 departments being represented in the 7 meetings. So outside of the results of the survey that we are going to go over, the meetings that we shared were shared over 7 meetings, 7 weeks of material for the committee. As you can see, there were an array of topics that were covered during those meetings. We started out with the leadership overview. We also shared the ABCs of benefits, which were just like the basic terms and terminologies of benefits. Also, we shared information from Gallagher, Cigna, and Humana, and we also shared some cost containment strategies that employers often consider when they are trying to assess costs for health insurance. And again, all of this information regarding the notes, the recording, all of that material can be found on the internet. All right, so we're going to jump into the results of the survey. The Human Resource received 450 responses from employees and retirees. Of those who identified themselves, 396 identified themselves as employees, and 39 identified themselves as retirees. There were 15 that did not respond to the question. Okay. Also, with the second question that we asked with the years of service with Richland County, those who provided their years of service, about 25%, as you can see with this number, identified themselves as being with the county for 0 to 5 years. Okay, and then you can see the breakdown based on the brackets of years. Majority of those who provided the years were 0 to 5 years. So as you all know, the survey consisted of 23 questions. So again, we do not want to take up a lot of the time that is designated for you all to share your questions and comments. We wanted to only pick out a couple of the survey results to share with you. And again, this entire presentation, as well as the survey results, will be available on the intranet after this meeting, sometime before Monday. All right. So looking at question two said, if currently enrolled, which health plan are you enrolled in? As you can see by the responses, 71% is enrolled in the choice plan, 166 enrolled in the standard plan, and 180 in the buy-up. And then we had 16 of those responded are in the Humana, the retiree plan. Question three, if currently enrolled, which tier of coverage do you have? Retiree or employee only, 284 of the respondents are enrolled in that tier. And then, of course, with spouse coverage, we had 30. Those who have employee or retiree and children, 86. And then for full family coverage, we had 32 of the respondents identified in that category. All right. The question 6 was, I am satisfied with Richland County government's health insurance offerings. We had 105 to say that they strongly agree, 239 to say that they agreed. Then we had 76 to say that they disagree, and 26 to strongly disagree, and 4 provided no response. For question 8, the question was, Richland County government's health insurance costs are. We had 55 to say was too excessive. I'm sorry, not expensive. 292 was reasonable, and 100 said that it's too expensive. So those were the responses to question 8. For question 10, do you think employees and retirees should pay more if they have 2 or more children on health insurance? We had 184 to respond yes, and we had 248 to say no. All right, and again, all of these responses have been collected and will be available on the intranet post this meeting. All right, and again, questions 21 through 23 were open-ended questions. All responses have been captured and are available to view as well. The unedited survey responses will be provided to County Administrator Brown and Assistant County Administrator Lori Thomas for their view during this particular process. During our comparisons, we compared the benefits of Richland County to multiple other entities that included Lexington County, Mecklenburg County, and the city of Charlotte. Overall, as Mr. Hanna mentioned earlier, the comparison shows our plans are rich and reasonably priced. All right. Also, we compared our plans with PEBA, which is the state health insurance plan. PEBA is the largest plan in South Carolina. They cover about 268 employees. They cover state, higher education, school districts, and about 34 to 46 counties and cities and towns, which also includes the city of Columbia. A lot of times the Human Resource Office will get questions regarding have we gone out to market or completed RFPs for to consider going to another entity. We wanted to share that just in the last couple of years, we have gone out to market what is out there in the market, comparing our insurance with other entities to ensure that we are offering the best quality insurance to our employees. We went out and did an RFP in 2001, 2003, 2008, also in 2011, 2014, 17, 19, and 21. We either did an RFP or did some type of external market review to show, to ensure that we were offering compatible benefits to our employees. Also, the carrier history that we've had, as you all know, for those who have been with us for a period of time, we were with Carolina Care Plan for 2020 and prior. We also were with Blue Cross and Blue Shield of South Carolina from 2009 to 2011. We also had our health insurance with WellPath from 2011 to 2013. And then we started with Coventry in 2013 to 2014. And then our relationship with Cigna started in 2014 to current. So this just gives you some type of historical standpoint of what we've done as far as to ensure our benefits are in line with market, as well as to show you our history with carriers. One of the defining things that I think that employees would want to know is how premiums are determined. When underwriters with health insurance oftentimes look at how they would price and how they would provide premiums to an entity regarding their health insurance, there are a number of factors that they consider. They consider the number of employees, dependents, and retirees that will be covered under the plan. Additionally, they look at the average age of employees. When the average age of employees are higher, underwriters anticipate more care and more services will be needed. All right, and that's just part of the equation when they're considering premiums. Additionally, they consider the plan experience and utilization. This includes like the claim history, how much the participants have used the actual plan, and a lot of times is calculated by the medical loss ratio. So the medical loss ratio is the percentage of premium dollars collected to the claim dollars paid. Just so that you know, last year, Richland County government's medical loss ratio was 100.7%. That means that Cigna paid more out in claims than Richland County paid them in premiums. And the premiums, of course, includes the portion that the county pays as the employer, as well as what the employee pays, which comes out of your paycheck. So they actually lost money on Richland County last year. To date, when we're talking about Cigna only, Richland County claims are $9.7 million more than the premiums that we have paid Cigna. This is a cumulative loss. So again, that means that in the premiums that we have paid Cigna, Cigna has paid in excess of $9.7 million more in what we've paid in claims. All right? As with most things, going to benefits and services built in the plan, as with most things, the more you add and include in a plan that's offered to a group, the more the plan is going to be. All right? So if we are going to, for instance, provide all the services that a carrier could provide to us, that price for the premium will be high. And so when we are building our plans, we have to consider, for the better hold of the group, what services we will provide. One of the services that we are asked about, especially in reading the surveys, is adding biometric surgery to our plans. We did a check with Cigna to see how much it would actually cost if we add for biometric procedures to be covered under our plan. There would be an estimated cost of 5 to 7% more added to our premiums just to cover bariatric surgery in our plan. And that would be basically an additional $1.2 to $1.7 million more that we would have to pay to include that particular benefit onto our plan. So as you see, the more that you add to the plan, the more expensive the plan will actually be. And of course, administrative costs are added to the factors that determines the premium. It is highly likely that the current plan without modification would require premium increases for 2023 based on current data. All right. Now let's look into some of the information that was provided by Cigna. In looking at our account as a whole, and this is just Richland County's information, Cigna reported that 50% of our employees, our members, have a chronic condition. And a chronic condition is a condition that's treated every month. Again, the members are anyone who is on our plan. This percentage of members are driving 83% of our total spend. So those that are included in this 50%, their services, et cetera, are driving 83% of our entire spend. As you can see, Cigna provided those conditions that are ranked high on the spend drivers. And again, that's hypertension, obesity, diabetes, and psychological conditions. All of these are our top spends regarding our plan. Cigna also provided that 53% of our our members are engaged in their health in some fashion. That could be the 47% that have their preventative care exams. And then they also provided that 70% of our chronic members are engaged in their health. All right? So this is information that Cigna provides because they are the ones that hold the individual information regarding our claims. All right, this is additional information provided by Cigna. As you can see, Richland County's pharmacy is above the norm when it comes to comparing us with other entities. In the overall, when you consider what I just mentioned in the previous slide about 50% of our members have a chronic condition, of course, you would probably think that that will also parallel with our prescription usage, which it does. Typically, chronic conditions are treated with medication. So because we have 50% of our population that is living with a chronic condition, this is not necessarily bad that we have higher prescription costs. It matches what our medical costs or our medical trends are. The first table, Richland County is trending high in each of the 4 areas, as you can see. Overall, the trend of our claims have increased about 16.2%. And you can see the breakdown of the individual categories. In the second table, by spend, you will see what classes and conditions Richland County is spending the most funds on. And this, of course, is by the actual condition themselves. All right, and then when you consider our key conditions, Richland County is actually above when it comes to hypertension. We are below when the norms when it comes to diabetes. We are above when it comes to depression, and we are spot on comparing to the norms regarding cholesterol. All right. Breaking down the data, comparing active employees stats to retirees. The current slide is what we will cover regarding active employees. All right. Our medical trend for active employees only, because remember, with our benefits, we have our active employees as well as our under 65 retirees that can take part in our benefits plan. All right. So for employees only, the medical trend increased by 13.8% for active employees only. The pharmacy trend increased by an additional 20.1% for pharmacy spend only. Average total combined trend is an increase of 15.2%. Employees comparing themselves represent 65% of the total population and 80% of the spend for active employee costs. Employees incur 21% higher costs than their spouses. And there you would see the first set of bullets of those top conditions by spend that employees rank higher in. Followed by that, you will see the top drugs by volume of our top spends. Of course, your cholesterol, hypertension, diabetes, and asthma. Overall, our medical loss ratio currently is 84%. Again, this is for our active employees. For our retiree medical trend has increased 10.1% at the time that this information was provided by Cigna. Their pharmacy spend actually decreased 7.8%. So overall, the average total plan trend increased 3.4%. And again, the same with our retirees. You can see the top conditions by spend and the top drugs by volume. And their total current medical loss ratio is 137%. Okay, I hope that helps you some, to get you some ground on, so when we start talking about the numbers, how the numbers are calculated. All right. So now I will share the floor with Assistant County Administrator, Ms. Lori Thomas, to present the second part of the presentation.
Thank you, Trina. Can you hear me?
I can hear you, Ms. Thomas.
Yes,
Great.
ma'am.
Thank you very much.
Yes.
Thank you all. And let me just thank HR and all the participants of I.M.P.A.C.T. We spent about 14 hours together talking about lots of different topics related to health insurance, and I learned a lot. And so I'm certain that everyone else did as well. And I appreciate the opportunity to participate today to talk about some of the things that we did talk about. So some of the things that we discussed during the meetings that we held with staff were the cost containment strategies that some employers use. That includes benefit inclusions and exclusions. That means plan design, what we will pay or what our plan will or will not pay for and how much it will pay for during those times. Co-payments for visits on PPO plans. That's what you pay when you go to the doctor's office. Your co-insurance amounts, and just so you know, that's what you pay above your deductible, in case there's any question there. You're familiar, our high deductible plan, or I'm sorry, our buy-up plan has a $500 deductible. Our standard plan has a $1,000 deductible currently. However, once you pay that deductible on your buy-up plan, it's an 80-20 plan, which means the plan pays 80%, the employee pays 20%. The standard plan, however, only is a 70-30 spend. So the plan pays 70% and the employee pays 30%. That's a little unique to most plans. We talked about consumer directed health plans. That's your choice plans, your HSAs, where you take a higher deductible and you take that risk. And a lot of times you find your healthiest employees try to go for this because it is a less expensive option, and they feel that they can contain their costs. We talked about cost share, and that's the allocation of premiums, employer versus employee. Just so you're aware, the average premium paid by the county is 87% of an employee's health benefits cost. That's extremely high. That's very rich in addition to having a rich plan. We talked about deductibles and how those are a component that could be increased to lower costs. We talked about dependent coverage and eligibility. One thing specifically that's over on the other column is spousal coverage. And if a spouse has, in many instances, if a spouse has eligibility somewhere else, plans won't allow you to enroll that spouse nor employees nor children that have access above certain ages. For instance, disabled children over the age of 26, if they have an option for care somewhere else, they may not be eligible for the plan. So those are some things we talked about. Dependent verification, this is often called an employee audit, so that you have to prove that you have the ability to insure that dependent by some legal means. Funding types, a self-funded plan versus a fully insured plan. We are fully insured. That means that we pay a premium and the insurer takes the risk. With Cigna for the last few years, they have risked $9.7 million. In other words, they have paid out $9.7 million more than we have paid them in premiums. That's a hefty risk. And the longer that continues, the more difficult it is for a carrier to insure us. A self-funded plan, though, right now would be extremely risky as well for us because our loss ratios have been so high. So we really don't know where those plan costs would come in and what plan design would need to be in place to be able to control those costs. One thing that I know has been near and dear to Director Hannah's heart for a long time is an on-site wellness clinic. This would be somewhere where employees and potentially insured dependents may be able to seek care for minor illnesses, employee evaluations such as annual physicals, things of that nature. Those are great cost containment items for employees as well as employers who have self-funded plans because they can drive that care to the on-site wellness center. It's also a great tool for a wellness program because you can actually gear your wellness program to be more outcomes-based rather than participatory by actually setting goals for employees that are medically set by a medical professional that they must achieve to be able to get that wellness incentive. And that tends to increase employee awareness of their health. Out-of-pocket maximums could be increased. The premiums could be increased for employees. As I said, currently, the county average is paying 87% of the premiums for employees. And what that means is that, as Trina was saying earlier, currently we could be looking at let's say we had a 5% premium increase from Cigna. How do we divide that up? That doesn't mean a 5% increase for just the employee. That would mean also somehow we have to account for that 87% of that 5%. And who's going to pay that? Would it be the county or the employee paying some portion of that? Prescription drug benefits. We have two different prescription drug benefits. The buy-up plan has a different plan from the standard and the choice plan. But those are things that many employers look at as increasing the cost of prescription drugs. That sometimes can be a double-edged sword because employees, the more expensive their drugs get, the less likely they are to be compliant on chronic conditions. Additionally, prescription drug step therapy, if your physician asks for you to take on a new drug and it's new to the market, they might be, the carrier may request that you actually go through what's called step therapy. In other words, trying less expensive alternatives before they actually approve the drug that's being prescribed if it's more costly. Spousal surcharges, as I said, is quite common in the marketplaces. And that's that if your spouse has an option for coverage somewhere else, they pay more to be on your plan. I know that Blue Cross Blue Shield a few years ago actually charged their employees $80 a month to cover their spouses if they had access for coverage somewhere else. Telehealth and telemedicine. That's becoming much more prevalent now rather than actual office visits. Those are less expensive options. Tobacco surcharge. This is something that I've seen in a lot of different plans. And just so you know, in our survey, 70% of those respondents supported tobacco users or anybody on the plan who is a tobacco user to have to pay a premium for their coverage. And I know where I came from previously, it cost you $60 a month if you had dependent coverage and you were a tobacco user or your spouse or dependent was. And then, of course, wellness initiatives that we talked about. We have a very high participation in our wellness program, but we might need to look at tweaking some of those requirements for initiatives. Not any one of these things is a silver bullet. This will not get us to a point where we can make our plan sustainable, but we can look at a lot of these cost containment strategies, but they would take time. And we are on a limited amount of resources. So if you go to the next slide, please. Trina. Thank you. So these next two slides are going to compare for you our current Cigna plans and the South Carolina Employee Benefits Association plan. That is what we call affectionately the PEBA plan. And you ask me, why are there only two plans out there? There are a lot of other carriers. Let me give you a little bit of history on what the county has done in the last 12 months. Actually less than that, about the last 7 months. We went out to the market and asked for other carriers to bid, if you will, on our business to ensure Richland County employees and retirees. We specifically retirees under 65 because your post 65 employees actually fall into a different category. And I would make that distinction very clearly on this. We had 3 respondents come back and give us costs. And when it all came down to the numbers factor, we looked at Blue Cross Blue Shield, Aetna, we asked for United Healthcare. We went to every market there was. Only 3 carriers would bid our business, and that was Cigna, Blue Cross Blue Shield, and Aetna. And a lot of that has to do with our loss ratios. If you are a driver with automobile insurance, you're probably aware that if you have a record of accidents and of high claims costs related to your car, it becomes harder for you to make a change in your health, in your car insurance. Health insurance for large groups is very similar to that. They look at what you've cost people or what your spend is before they would commit to writing your business. Last year, Cigna did come back with us. They had actually originally proposed to us an 11.8% cost increase. They came back and agreed to hold our rates if we did certain things, and it was not in a straight premium method. There were some negotiations back and forth, but ultimately for the county, it meant that we could hold our premiums for us and for our employees for 1 year. We reached out to the state employee health plan and asked them if they would be willing to take on Richland County as an optional employer. And they said that they would. Because we knew the others cost the same thing or more to actually make a transition for, that's the only reason that you're only seeing these 2 options here. We actually asked Gallagher, who was a benefits consultant that helped us with this comparison, to actually compare these plans for us. And what you're seeing there to the left-hand side under the Cigna is our 3 plans and what their design, their typical benefits design is. To the right-hand side, the 2 plans that PEBA offers are a standard plan, which is an 80-20 plan, which is very comparable to our buy-up plan from a deductible perspective, but better than our standard plan from a deductible perspective, or no, it's comparable on a deductibles perspective. And there are some other nuances to this with relation to other coverages. The other that you see there is their savings plan, which is comparable to our high deductible health plan. I will tell you, it has a higher deductible and a higher out-of-pocket maximum, but it is the comparable plan. What you don't see on this screen is that if we were to choose to go into this option for any employees that we have that have access to coverage through the military, they also offer a TRICARE plan that you would have an option to elect. That would have a lesser cost for those employees who qualify for that coverage, but would cost the county the same amount. If you go to the next page, please. This is the second page of what's called the standard benefits design, and this is actually just a comparison of normal benefits that you would see in any normal benefits booklet. If you'd like to see details of this, of course, you already have access to the Cigna plan and the state employee health plan benefits. We can also send you in the material that's on the intranet available during the presentation is a link to the entire South Carolina PEBA health booklet. You go to the next plan, please. The next slide, please. So the next thing that we wanted to look at not only was cost related to the county, because we've also already told you that on the long term, that's not sustainable because we only see costs increasing. But we also wanted to look at what would this mean to employees and their premiums. To the left-hand side in the first group there is your buy-up plan. That's your, and what you're seeing is the per pay period cost for that in the first column under employee/PP. The next group of costs where you also see employee through family is your standard plan. And the last is what's currently our choice plan. These are compared on the right-hand side beyond the blue line to the PEBA costs. Keep in mind that because there's not a buy-up plan available through PEBA, we have allocated what would be the standard cost for those people on the high deductible or on our buy-up plan, excuse me. I have a hard time with that. You will see what the annual costs for employees are, what the annual costs for employers are under both scenarios, both Cigna and for PEBA. And to the far right-hand side, you would see what the annual impact to employees on premiums would be. This is either savings, which are in positive numbers, or additional costs, which are in parentheses. We are looking that if this was an option that we felt employees are significantly interested in how to make those costs that were those places that are negatively impacted cost neutral for those coverage groups. Also, I'd like to point out that given our current loss ratios, it is highly unlikely that we will not have a premium increase from Cigna going forward next year, which would mean that at some point in time, we have to look at how we allocate those costs. Either the county's costs increase, the employees' costs increase, or both. So if you would go on to the next slide, please. The next comparison that we've done is to actually give you a snapshot based upon our current enrollment and potential full enrollment and what these impacted costs are to the county and the employee overall. The first group there titled Current Enrollment shows you our current enrollment of all classes of insureds, and retirees under 65, retirees over 65, and active employees. I would point out to those retirees over 65, and I know that you're not on this call right now, but I'm certain this would be a question that will come up if they're reviewing this, is that the difference there in expense is for dependent coverage. It does not impact actual employee coverage or retiree coverage. But as you see there, the current cost for our coverage for these work groups is $21.2 million. This is only health insurance. This does not include vision, dental, or any other coverages that the county may be paying for. The current enrollees cost is $2.89 million. If we were covered under the PEBA cost, on the outside, we estimate that this would be less than $13 million and about $2.2 million for employees. You'll notice those two columns there in yellow, or the two cells there in yellow. One would be the cost for the county to make sure that no one paid more in premium next year than they currently are paying. In other words, those groups that were negatively impacted on the prior slide. The next item there is that with the standard PPO plan through the state health plan, there is a deductible that must be met before you go to copay arrangements. This would be the cost if the county were to pay the first deductible on those plans. And these are just suggested scenarios. We don't know that this would be accepted. We don't know that this is possible. We don't know that you all have an interest in it. But we wanted to show you what that looked like and what this would still mean in savings. The current enrollment average costs are in the next section there, directly below current enrollment. Currently, the employer pays on average for an under 65 retiree $14,600 a year in coverage. For over 65, it's about $2,200. And for average active employees, it's almost $12,000. You can also see the employee costs there. Under the PEBA scenario for under 65 retirees, you would be at about $5,700 a year and about $6,000 for active retirees. It would cost the county more money to insure those over 65 employees, but as a net, that is still a positive position for the county. Finally, the last set of numbers there are what it would cost the county if we reach full enrollment. So in other words, if we were fully staffed, right now we have about a 20% vacancy rate within the county. If we reach full employment, we're looking at $25.4 million, which is significantly more than we have budgeted for health insurance costs for these groups. You'll notice that the over 65 retirees and the under 65 retirees, we did not change significantly because we really don't know what those numbers would be. We just used some averages. The same is there for the state employee health plan, along with the additional costs that would be accrued there. To your right there, I've done an actual calculation of current enrollment and the cost of the plan, as well as the total employee retiree contribution. What PEBA's cost would be with the allowances that we would suggest, along with what those differences are. The net there is that the county would still save $8.2 million under current enrollment for active employees, in total, and $600,000 for employee retiree contributions. Thus, a 39% savings overall and a 21% savings for the employee retiree contribution. So that's a significant amount in our estimation. With this, what I would also point out is that one of the important considerations here is that we have limited resources. If we're able to realign some of the costs that are paid for benefits, we may be able to address some other issues such as compensation, training, and additional staffing and equipment that the county may need. We're not saying that these would necessarily go back into programs, but that the majority of these numbers would be suggested to go back into some sort of a program to ensure that we can retain and attract the most qualified individuals. Go to the next slide, please. So this slide here was also done by Gallagher, and it points out some of the differences in the PEBA plan, and they're not all positive. I'm going to be very frank with you. The PEBA plan is a grandfathered plan. It does have a deductible before you actually begin to go to co-pays, but again, the county is looking at some options to be able to address that. You also have a $3,000 prescription drug out-of-pocket maximum that is not embedded in your deductible. However, they do have a very large program of generics and tiering system through their pharmacy program. The standard plan wellness visits are limited somewhat, but there are some ways that you can actually alleviate these by using what is called PEBA perks. Their savings plan requires coinsurance after the deductible is met. Their savings plan does not come with employer seed money to the HSA. I have reached out to PEBA to find out if the county could make those, and I'm waiting on confirmation of that fact. And as I said earlier, the deductibles and coinsurances of in and out of network are not, well, this is an additional cost. If you choose to go out of network, your deductibles that you meet there will not be applied to your accumulation of deductibles. However, our current out of network spend is below one. It is about the 1% measure. Next slide, please. So just a quick slide on some of the pros and cons in layman's terms. The pros of the PEBA plan, it's financially sustainable. The employees on the PEBA plan have not seen an increase in the cost of the standard plan since 2015, and that is something that's relatively unheard of. A lot of that circles around the fact that it remains a grandfathered plan, and that is one of the ways that they stay compliant with that. The buying power, they're able to keep those costs under control because they insure over 268,000 employees, which means an even higher number of lives in the state. It's competitive with other governments for recruiting. All of your state employees, your higher education, your educational, your school districts, and 34 of 46 counties, plus municipalities and other local governments are actually enrolled in this program. PEBA perks allows you to save on some of your other costs, and those are outlined in their booklet there. And the reduced costs are making it possible to fund other things. As I just said, we have limited resources. The cons, we get no claims data from PEBA, so we don't actually know how much we're spending on healthcare. We know what our premiums are, but we don't know where our health costs are trending. We would have to make a 4-year commitment to the PEBA system. And that is significant. However, again, they are financially sustainable. There's a learning curve. Employees would have to learn to maneuver in the PEBA system and actually have to learn to use the Blue Cross system as opposed to the Cigna system. Employees would have to meet their deductible prior to the copay for office visits. As we said, we are looking at how that impacts and what the county might be able to do there if this was something employees are interested in. The pharmacy deductible is outside of the normal deductible, and potential changes to retiree dependent costs and those with less than 100% premium coverage. So, being very upfront with you, these are the largest concerns that I would see, but all of these are outlined in the full presentations that we went through in the impact study. Next slide. So at that point, I'm going to turn it over to our county administrator, Mr. Leonardo Brown, and he'd like to address the group.
So good morning to everyone. I know we're running short on time here, but I just simply wanted to make sure that everyone on the call this morning was clear that no decisions have been made at this point. This process that we're going through was to get input, to get feedback from the community of employees and retirees to help us as we try to consider how to balance our compensation package. We talked about the sustainability of increased costs concerning the healthcare, and we're trying to balance a good business wellness plan as well as try to figure out ways to increase wages, and that's part of some of this driver. So again, I don't want anybody to leave this presentation today thinking, oh no, the county's already decided what they're going to do. The county has not. I expect that there will be many conversations that will take place in the form of work sessions with county council, which will be public discussions about potential actions associated with plan changes, whether there are plan changes within our current plan or whether there are plan changes to another plan. But I just wanted to encourage everyone to stay tuned. Please be informed. Please take this serious. We want your input and feedback, and we appreciate everybody that's done so thus far. Thank you to HR. Thank you to our budget and finance team who's took a deep dive into this. And the next step really is to continue to discuss this, hear feedback, and then look forward to discussions with the county council based off our healthcare assessment. So thank you again for what you do. And that concludes my remarks.
Thank you very much. We have a question from Miss English. Miss English, you may unmute yourself.
There we go. Thank you, everyone. I really appreciate this. This is just a quick question, and you may not be able to answer it now, but I'm currently a state employee, and we are under PEBA. And right now, I have the dual insurance. What would that do for those employees like myself who are already under PEBA? And like I said, you may not be able to answer that now.
Ms. English, can you define dual insurance, please?
Sure. Under when I go to the doctor now, what PEBA doesn't cover, Cigna does.
That option would no longer be available because the Cigna plan would not be available through us.
So I would just have one health insurance. I wouldn't. Who would cover me, the county or the state?
Given that you're on the state plan currently, you would remain on the state plan, but I would have to clarify that. I believe that's how I read it, but I need to clarify that.
Okay, that's fine. That's just a question that I wanted to just get some answers to.
Sure, thank you.
Thank you, I appreciate it.
Mr. Broderick, you may ask your question.
Hello, can you hear me? Can you hear me?
Yes.
Yes, sir. We can hear you.
Okay. My first question would be, am I allowed to give an honest critique without fear of reprisal?
This is Dwight Hannah. I assure you the Impact Committee, through their 7 meetings in 14 hours, were very candid and honest with me, and we were all receptive to their input.
All right. Well, thank you for that. I'd just like to make a few comments, and my critique is pretty harsh at some points. Me personally, and this is all my own opinion, is I think that changing some of these issues or some of these points are almost like a change in terms and conditions of employment. I think that when a person signs on, they sign a contract that guarantees them certain benefits, and that's the reason that they took the job in the first place. And I think by making some of these changes, if you decrease those benefits, then you're basically decreasing the terms and conditions of that employment. Secondly, I would say that from the outside looking in, it appears that and with all due respect to Mr. Brown, it appears that these decisions have been made based on the overall cost savings that it's going to bring to the county as an end result. And I think those cost savings are going to be borne by the employees themselves. And I don't see anywhere in any of those options in there where the increased costs are passed on to the consumer in the form of a tax increase. No one wants to hear the word tax increase, but we're in an inflationary environment, and sometimes cost increase do occur. And sometimes those cost increases are borne by the consumer, not only by labor. Corporations. Well, one of the other things that I wanted to mention was that I don't see another option in there that says benefits and premiums would stay the same for current employees, and those proposed changes could be passed along to new employees. Based on your own data and your own slides, 25% of the employees for the county have less than 5 years of employment here. If that proposal or that option was put in there within 5 years, 25% savings would be realized from new employees being brought onto the city. You have a 20% vacancy rate, and you have 25% of your current employees with less than 5 years. So if you bring on that 20% employees and continue that trend, the cost savings would be realized, but over time would not a sudden and dramatic impact on current employees. Let me just look at a couple of more notes that I have here. And I'm going to step aside. I would just ask that when these proposals are put forth, that it actually appears, or that it's shown to be, not that every employee is in agreement, because some plans are put forth and presentations like this are made sort of as what we used to call a fingerprint plan, just trying to get fingerprints on it to say everybody looked at it, everybody agreed to it, everybody understood it. And that's not always the case. And in this instance, I don't believe this is the case either. So a lot of people may see it, but a lot more people that are not speaking out against it may be against it. And I'm not saying that I'm for or against it. I'm just saying that there are some options that I don't believe is in this plan. Thank you.
This is
Thank you.
Dwight Hannah. Thank you for your comments.
Yeah, Mr. Hannah, just real quick, and I do appreciate the comments. I did just want to clarify, and I respect the feelings and the thoughts, but no decisions have been made. I just want to reemphasize that no decisions have been made regarding the healthcare plan. And I could have already made decisions. No decisions have already been made. So want to make sure that's clear for everyone that that's the case. Thank you.
Mr.
Can I make one more comment before I've done? Just one more thing, and I'm done. There was mention at the beginning of the presentation that there was a possibility of dealing with a plan that would have resulted in a $10 million to $12 million savings on the behalf of the council. And then later on in the presentation, they were saying, with limited resources, we're looking at possibly salary increases or training opportunities. But because you said we have limited resources, but also employees have limited resources. And it's extremely difficult to tell an employee that they're going to get a 1% salary increase at the same time their insurance premiums are going to go over 150%. So it's extremely, extremely difficult to try to justify one with the other. Thank you.
This is Dwight Hannah. I'll just mention two things in response of, three things. First of all the comments that you made, I made a note of them in regards to not all employees agreeing. We certainly acknowledge that. We know that. We've read the survey responses. They don't all agree. All members of the I.M.P.A.C.T committee did not agree. And we're sure, regardless to the decision that is made, that out of about 2,000 or more employees and retirees, I am 100% confident that there will not be agreement. So we do understand that. The other comment that I'll make is that as it relates to the changes, and again, Administrator Brown has spoke to no decision being made, but the county council has an option to make changes in the health plan if they decide to do so. I'm not saying they have decided to do so, but they do have that right to make the changes if they decide to do so. Thank you.
Ms. Whitmire, you are eligible to speak and unmute yourself, please. All right, Corley K, you are able to ask your question. Please unmute.
Lauren, is she speaking? I know I can't hear. I don't know if others can hear or not.
No, sir. Mr. Hopkins, please ask your question.
Lauren, I am still not hearing. I don't know if others.
Yeah, Mr. Hopkins, there you are. Yes, sir.
I have like two quick questions. The first question is, would a outcome-based wellness program significantly reduce costs for the program to maintain the same level of benefits? And my second question, has the county considered having an in-house clinic and pharmacy as a cost containment measure?
This is Dwight Hannah. I'll respond. And I don't know if Ms. Thomas or Mr. Brown would like to say anything. Taking your last question first, yes, as it relates to considering pharmacy, health, employee health center, some people call it clinic, health center, yes. In fact, I started looking at the City of Columbia's model many years ago, probably over 8 years ago, which they did years ago, have a pharmacy where they dispensed only generic, commonly used prescriptions for employees without a copay. And they said that in itself was a significant savings. And earlier in the presentation, Ms. Thomas mentioned that that's something that certainly I and many in the county have looked at and have an interest in. To respond to your first question, an outcomes-based wellness program would, in all likelihood, save some. How much is a question I could not answer with precision, but obviously there are pros and cons to that. Many people are resistant to outcome-based programs, but certainly the voluntary wellness programs that we've had over the years, while we've had many, we have good participation, and there are certainly many very successful, stories of employees getting off medication, losing weight. Overall, as you can see by some of the results that we presented, it has not resulted in enough reduction in claims to get us in a good direction. So the short answer on your first question is I don't have a precise number on an outcomes-based program in terms of how much difference it would make, but I am certain an outcomes-based program would make some progress. Thank you.
All right, thank you very much. Our next question is from Mr. Brian Crooks. You are able to unmute yourself and ask your question.
Good morning. Can you hear me?
Yes.
Okay. So I had a couple of questions. One was, I think Ms. Thomas mentioned earlier in the presentation that in terms of the coverages for the PEBA, those are listed in their handbook. Did I hear that correctly?
Yes.
Okay. So in terms of PEBA, their coverages, are they the same or similar enough to what is offered through Cigna currently, in terms of how the cost function would be and overall coverages of services?
If you look at page 26 and 27, there's a general overview of basic costs. There are some changes, but they're similar. They are similar. The premiums cost employees less, even compared to what we pay now, what our employees pay now. Generally, we're also looking at methods that would ensure that wouldn't happen next year, that nobody would pay more. But to actually specifically address the benefits that you are looking at, I would encourage you to look at pages 26 and 27, or 25 and 26 rather. 26 and 27 of the presentation. And then the link for the PEBA handbook that gets very in detail to it is in the impact information, and I'll be happy to send that to you as well, Mr. Crooks.
Okay.
Ms. Thomas, I can do that for you. And I was just going to add that, and it's been mentioned, Brian, that we had a neutral third party, Gallagher. I think Ms. Thomas mentioned this in her presentation, to do a comprehensive analysis. And there is details, as Ms. Thomas mentioned, very detailed analysis and comparison in terms of pros and cons, which you will see. But we just couldn't fit everything 14 hours into an hour or two. That's all. Thank you.
Gotcha. So another question I had, so in reference to the PEBA plan, would they still be providing the HSA, or would it be flex spending, or do we know yet?
They do have options for that in their plan. I think their FSA is called Money Plus, and they do have an option for an HSA plan. What I'm also trying to determine right now is I know that currently with our HSA plan, the county does seed that for employees. I'm trying to find out if that would still be a possibility as well.
Okay. And then I think my final question at the moment, would we still be offering, I guess, on-site biometrics and the like? Because it looks like through PEBA, they mentioned and I think you mentioned it earlier, Ms. Thomas, the PEBA plus benefits or something. But I just wanted to ask about that in relation to the on-site biometrics, because if they're looking like in the PEBA thing, and I'm just kind of scrolling through it, the preventative screenings, depending on your age range, it varies for, how often you can do those for your age. So I just wanted to know if we'd still be offering that on a regular basis annually at the county if we were to move to that plan, versus the onus being on the employee to get their preventative screening. But if they're only able to do so often, I just wanted to know if we'd be looking at that also.
Certainly something we could consider. Biometrics for the most part are relatively inexpensive. You generally pay per participant. So while it's not been a specific discussion, we certainly can discuss that.
Mr. Crooks, if I can elaborate on that response a little bit, one of the things that we were hoping that employees and retirees would do, and probably employees more because they have a wider breadth of things to consider, is that a lot of these decisions that are being considered are really multi-pronged. So for example, as I communicated earlier, while no decision has been made, one decision does not necessarily lead to another. So part of our potential consideration would be, how do we, again, balance any changes that we would make so that they would not negatively affect the outcome that we're trying to achieve with healthcare. So someone asked a question about a wellness clinic that will be provided by Richland County. Well, that will be something that the county could do that will perform the biometric services that you're talking about. That would be something potentially that the county could do, if it pursued some different option than we have now. So because that wellness clinic certainly requires additional funding to address those on-site opportunities. So to your question, those are some of the things that we're trying to all balance out so that, employees don't feel like, well, I'm losing out on something. Certainly changes with any plan, there are always something that, one person may gain and another person may lose. That's the nature of group plans. But we are really trying to look at a holistic view of how do we attack this issue and not cause a loss of value to our employees as it relates to their health care and wellness.
Thank you, Mr. Brown, Ms. Thomas.
Thank
Those
you.
are, I think, all my questions at the moment.
All right, Ms. Gaston, you are able to ask your question, and please unmute yourself.
Okay, are you able to hear me? Okay.
Yes, ma'am.
All right. I had a unique experience in that I've to have both at one point the PEBA plan and now I'm on the Cigna plan, and I understand the savings to the county that would potentially be offered with this PEBA plan. However, the out-of-pocket cost to each employee is significantly higher. And I'm not talking, just a couple $100s a year, like it is substantially higher. And I also see in the proposed benefits that those of us who are 18 to 39 would only have one wellness visit covered every 3 years. That certainly doesn't help, with the rising, the amount of disease and cancer that we see today. And while I understand that it might be saving money to the county, I think it affects us on an individual level because we'll be paying all of that out of pocket. So most of the appeal in these state jobs are the benefits. And so frankly, it seems as though if you consider taking that away for maybe, I don't know, a possible 1% increase in pay, that's not even going to be close to offsetting what we're going to be paying out of pocket.
Ms. Gaston, do you mind if I ask you a question about your experience with the PEBA plan, ma'am? This is Leonardo.
Absolutely.
You mentioned that you experienced a lot more out of pocket. Are you referring specifically to the deductibles, or are you referring to something else related to the plan?
If I went to the dentist or a regular doctor's visit, I was paying hundreds of dollars, and now I'm paying, I think it's a $35 copay, which is much more reasonable. And for those of us who have to go to the doctor regularly, and by that I mean once a year, especially us who are females, it's much more reasonable to pay $35 than to pay hundreds of dollars. Or when you go to the dentist, you have to pay for every single cleaning out of pocket.
Thank you. And one follow-up question is that, do you still pay that hundreds of dollars after you've met your deductible? Or is that literally you're talking about until you meet your deductible, you have to pay the out-of-pocket? I'm just trying to clarify.
I think the plan that I had, it made it pretty much impossible to even get close to the deductible unless there was some sort of catastrophic event where I was in the hospital and be there for a few days. So it's set up in a way that you are almost not going to meet the deductible, which means that you are going to be paying out of pocket every year.
Gotcha. And I appreciate that. And I've been on a number of different plans. So I was asking because one of the things that we mentioned, and we did not guarantee this because, again, nothing really has been decided because nothing has been voted on by council. Nothing has been presented to council. So there are a lot of things that are just information. So we can't say things will be one way or the other because we don't know that. We don't even know if the council will want to consider this at all. But one of the things that we did try to do in looking at the deductible was we actually looked at the county paying the deductible so that that's not an issue. So employees would not be hindered by having to meet a deductible before utilization. So would have not affected your situation if the employer had done that. But I'm just trying to make sure that when we're trying to figure this thing out and look at potential issues that are brought up, that we can kind of address those. So I appreciate your comments. Thank you very much for your sharing your experience.
Yes, sir. I mean, I think my thing with that suggestion is if the county is willing to pay the deductible of each individual employee, then perhaps we should pay the extra to keep Cigna.
So the reason why that would be manageable is because if you looked at the amount of funds that would be available, that's what would afford you to do that. You couldn't do it both ways. So if you want to talk about it and look at the details a little bit more, we can share that with you, but one is not exactly the same as the other. It's not apples to apples.
All right, the next question is from Corley, Kendall Corley. You are eligible right now to ask your question or state your comment.
I just figured out how to unmute myself, sorry. This is kind of a random question. Has anybody looked with anesthesiologists?
Lauren, I did not hear all the questions.
Yes, Ms. Corley, can you ask that question again, please?
Yes, can y'all hear me now?
Yes, ma'am.
Okay, just out of curiosity, has anybody looked into what, if anything, we can do with anesthesiologists?
I believe the question was, is there anything that can be done for anesthesiologists?
Yes, apparently they're all out of network now. And for someone like me who has surgery times a year.
I'm sorry, did you say for someone who has surgery several times a year, all of the anesthesiologists are out of network? Is that what you're conveying?
Correct. Yes.
Okay.
Yeah, I'll just say from my experience, ma'am, and this is across 3 different states. In general, anesthesiologists are not in-network providers. I actually haven't been on the plan in Louisiana, Texas, or South Carolina where anesthesiologists are ever in-network. So I think it's more of a industry thing, not so much a Richland County plan thing. But I'll certainly let anyone here who has lived in South Carolina may have specific information about the state clarify any of that. I'm just speaking from my experience across health plans in 3 different states.
Mr. Brown, this is Dwight. Not speaking across other states, but your comment is generally correct as I know it. And I have a friend that's an anesthesiologist, and she likes to say they get paid to wake you up, not put you to sleep. So it's not that whether it's Cigna or Blue Cross or Aetna, whoever does not want them in the network, they can only offer them. And if they do not wish to be in the network or have decided their services are so important, they can, I guess, do well and not join the network. That is, from what I can understand, a decision of the anesthesiologist in general versus whether it's Blue Cross or Cigna or Aetna, not wanting them to be a part of a network. But I haven't looked into this a while. I'll be glad to check with Cigna and maybe Blue Cross too, to see what they're currently saying about that. Thank you.
All right, thank you very much for your question. There is an employee by the name of Webster. You are now eligible to ask your question or state your comment.
Yeah, I had a question. I know currently I am participating in the that wellness incentive that's offered by Cigna for meeting all your goals throughout the year by the end of January 30th, and I didn't see anything or hear anything in response to that. And secondly, it's always my biggest concern about my doctors changing because they're not within that same network now. Do we have any kind of guarantee whether or not either of those options are still going to be available?
So I would say in general, we will be looking to have some form of wellness program. We think that there's value in the wellness program. And so that is something that we would be supporting. How that would look, not quite sure, but yes, sir, that's something I would just tell you point blank that I would be recommending that we have a wellness program, which is why I support the one that we have now. In reference to guarantees of doctors, so again, this is just from my experience, and so I'll try to balance this out. So the county can have a plan, and the plan can have a provider listed in the network, but then your provider can choose to not be in the network. So I think if you even look at the plans that you have now, if you go online and look up a doctor or a facility, I think there'll probably be some language on there that says something along the lines of that they don't guarantee, because they can never tell you when a provider, him or herself, or a facility may choose on their own not to be an active participant in the network that they once were a participant in. So there's always a chance that you have a provider who you don't have access to anymore. Again, I'm still relatively new to the state of South Carolina, so I'm not sure how large the Blue Cross Blue Shield network is. I understand that the PEBA plan would be a Blue Cross Blue Shield backed structure. And my understanding is that's supposed to be a rather large network. One of the things you could do, just again, and I'm not encouraging anyone to do this because the plan has been decided, because it hasn't, but what you could do, and what I would frequently tell people to do when we were talking about different organizations that we might look to change to, we would tell employees to check with your current provider and find out whether or not they accept a plan that you heard your employer might be looking into. So whether that was an Aetna, a United Healthcare, a Blue Cross Blue Shield, and then your provider could tell you whether or not they accept that provider, and particularly whether or not there's specific plans they accept from that provider, because they might not even accept all plans. So that would be one way you could just do a little homework and find out whether or not this is something you felt like would be comfortable for you, because you've talked to your provider that you routinely use and you know that he or she does or does not participate in a potential considered network. So that would be a step that you could actually take.
Okay.
Mr. Brown, if I could add, and I agree with what you said, if I could add to that, maybe for the broader group that's listening, over the years since I've been with the county, we have done RFPs numerous times. And one of the things that we have done is like a comprehensive, we call it like a disruption analysis for the network and also prescription drugs. And what I can tell you is no two plans are going to match precisely down to every single doctor. It's never going to happen. However, when you look at Blue Cross Blue Shield, and we were not looking at PEBA, we were looking at Blue Cross Blue Shield, but PEBA administers Blue Cross administers the plan. The Blue Cross network has been either slightly better or at least competitive with Cigna, Aetna, Carolina Care Plan, or whoever we were comparing it to. I think overall, the Blue Cross network would at least be equal, if not a little bit better. But say, for example, I think we were around 97% in terms of matches, or 98%. Well, that sounds great unless your doctor is in the 1 or 2%, and then you're 100% outside of the network. So again, everything will never match perfectly, but for the most part, in terms of the network, based on our experience in doing a very in-depth, detailed comparative analysis, the Blue Cross network has been even a little bit better in terms of the comparisons with the percentages. Thank you.
Thank you very much. Mr. Hopkins, if you would like to ask your question or state your comment, you may do so now.
Yeah, I have two questions. Basically, my first question is that has the county ever considered partnering up with other counties to see as a group that they can leverage down the cost for healthcare? And my second question is probably more directed towards administration in terms of, is there any consideration in terms of the budgeting process to examine increasing fees to offset some of the potential costs for healthcare? Thank you.
Dwight, I can take that. As far as partnering with other cities and counties, there was a pool that was set up by the Municipal Association for cities and counties many years ago, and that pool for health insurance dissolved because it could not stay solvent. So it appeared that what was happening was many of, I don't know whether it was smaller groups or just high risk or whatever, were going there and they could not sustain that. So they got out of that business, and they actually encouraged their groups to go to the state plan because the state plan would take them. They actually got them to agree to take them all that did. Some did, some didn't, some went to self-insured, depending on what their loss ratios, because the one thing that that group could do was give loss ratios. So I know in North Carolina, there is a pool, but it's run by a broker. So it's a for-profit group because you have to have a third-party administrator that's interested in doing that. And there are costs that are associated with it. To do that, I have not considered it. I have not looked at it because it would take a long time to actually even find out who your interested parties might be. Because keep in mind that 34 of your 46 counties are already in the state pool. And what was your second question again?
Ma'am, my second question was, in the budgeting process, has there been any consideration in terms of looking at fees or increasing fees to offset potential increases in employee healthcare costs?
You know, you can increase, we are bound accordingly to what some of the fees and such that we can increase are. And of course, that would be up to council to do those. And, you know, that there is some possibility there, but I don't know that we could do it to a point that, I mean, you're looking at a significant amount of money. You're looking at millions of dollars. I'm not certain that there's that much available. I mean, can you give me an example of types of fees that we could increase?
I think in terms of, you know, the possibility of what council could do, we can look at increasing fees in terms of things like application fees and stuff like that. I'm not saying to offset the total cost, but just to reduce some of the burden in terms of some of the hard decision making that the county is facing. So like application costs, copy costs, general fees like that. Now, in terms of millage rates and tax rates, in terms of property taxes, that will be a tough decision for council to make. But those fees I was just thinking about offhand.
Yeah, so let me touch bases. So it's a good question, and I like the thought process in terms of, you know, trying to think of ways that we could address the situation. There are two additional thoughts I would have you consider. One is for the last, and I know it's certainly is COVID related, but it's not all COVID related. But the county recently increased over the last, 2 years, fees as it relates to like some of our utility services, to try to catch up and get back on track with the costs associated with that really hadn't been addressed in a number of years. And I think what you would have in this situation is, because the county has kept a lot of its cost, I don't want to say low, because depending on the person that's paying it, it could be substantial for you, but because the county doesn't routinely increase cost, it's allowed things to build up over a number of years. And so you would really have a situation where you're increasing a lot of cost in terms of fees and fines and service charges at one time. And to your point, regardless of millage, I think that might be a hard pill for council to swallow. Also, I think you would have people who would ask, what has the county done to control its cost? And I think if you look at some of the spend, and I think for anyone who wants to look at the trend data, I think what you will find out is this is not a COVID related discussion. This is a healthcare claims related discussion over a number of years, not just COVID-19. So it's a larger question. But you raise some very valid options, but those are other things that you would probably have to address and deal with, is that you have other fees that you've already raised in the last couple of years. And then you have other issues in the county where you're going to be trying to ask the community to stomach some increases when they may also be looking at lost jobs, lost wages, and less disposable income. So we're trying to look at all those things. And so to that point, I want to remind everyone, we're talking about, the PEBA side of this, but we could also as easily be talking about some of the Cigna side. So one of the things that we reported out was Cigna last year was looking at an increase. And, through Director Hannah and his team, they were able to negotiate kind of keeping things neutral, if you will, to a certain degree. But they've taken losses from the county over a number of years, and no one's going to continue to generally just lose money and charge you the same rates. So we also could be talking about, what's the plan for us keeping the Cigna plan, which we might absolutely do, but that keeping that plan might still result in plan changes that are necessary because we can't keep things the way that they are. So we don't have to just focus on the PEBA question. So I don't want anybody to think that, because it's definitely not a decision that has been made. But we do know that there are going to be some changes in some shape, form, or fashion.
Mr. Brown, if I may add something here. I would point out that last year, one of the things before we actually got down to hard tactics negotiating, was PEBA proposed for us to eliminate the buy-up plan completely.
You said,
And that-
what you mean Cigna?
I mean, Cigna, I'm sorry. Cigna proposed us eliminate the buy-up plan completely because it's unsustainable. They knew it as well. So as Mr. Brown points out, we could be looking at situations where we have to do something like that. And additionally, we may have to increase premiums because the county is at a point where they're putting so much money into it now. The problem that you've also noticed is that, and I don't know about some of you, but I've heard over and over again, is that we've not been able to address compensation. Well, this is one of the reasons. We don't have the resources if we continue to put it here. Thank you.
I would, in response to Mr. Hopkins' question about having looked into working with, I don't know if you said other counties or local governments. I can speak to that specifically. Yes, we have over the years. Specifically, I don't know, 6, 7, 8 years ago, I talked extensively with the city about the possibility of the county permitting county employees to utilize their health clinic. Is right down the street from 2020. It would be convenient to many employees. It would save the county from building a separate building. We would just share the cost. But I think to one of the points Ms. Thomas alluded to, the logistics involved in that, I think they were with Blue Cross, not with PEBA, but Blue Cross at that time. I think we were with Coventry, getting the two insurance companies to agree. Then there's the fact of getting the county councils to agree. Well, we never got over the hurdle of getting the two insurance companies to agree, so it never got to that. So there's a lot of logistics involved when you try to get two entities to agree to something. And I have also, it's been many years ago, even talked with Lexington County about the possibility of doing some things together. But just the logistics involved in that thus far have been a hurdle that we haven't been able to get by. Thank you.
Any more questions or comments?
Lauren, if nobody else has any more questions, I'd just like to thank everyone for participating. Thank everyone for their questions. Thank everyone for their feedback. And just as we, I guess, sort of get ready to close, I think it's important that we look at whether it's PEBA, whether it's Blue Cross, or whether it's Cigna. They're different plans. It's not like Blue Cross is evil or Cigna is evil or PEBA is evil. They're just different plans. They're just different plans. So it's nobody bad or evil. My wife has been a state employee for many, many years, just retired last year. She was on the PEBA plan. At times she liked some things, at times she didn't. So, and we hear from employees, at times they like things about Cigna, at times they don't. So it's really the plan more so than it is, sometimes I hear, well, Cigna has good insurance. Really, the county is buying a plan with Cigna that is very rich. And I'm not talking negatively about Cigna. I'm just trying to make a point. It's the plan that the county buys versus Cigna or Blue Cross or Aetna that is giving us a good plan. It's the plan that we buy that makes the difference. It's the plan. We have over the years aggressively negotiate renewals, even when there weren't RFPs. And I think the fact that Cigna's lost $9 million is an attest to that. Not that I'm glad they've lost $9 million, but I think that shows that we're certainly, in terms of what we're getting, it's expensive because we have a rich plan, but it's not like we're overpaying Cigna for the plan that we're getting. We just have a very rich plan. Someone earlier was asking or was stating that they were on the PEBA plan and the out-of-pocket expenses were more. That is not anything that we're covering up or hiding from employees. Again, the detailed analysis was done by Gallagher, a third party, and you can see the details of that. Some of it was gone over today, but again, we didn't have 14 hours, so we couldn't go over everything. We have a lot of employees that have chronic illnesses. That's driving a lot of the claims costs as well. So again, thank everyone for your input. Thank you for your questions. You can email us if you have any additional questions. Lauren, did anyone else have their hand raised?
No, sir, not at this time.
So last thing I would like to say is thank you to Administrator Brown again for not only permitting us to have this type forum, but advocating it and promoting that we get input, questions, suggestions from employees on the front side before a decision is made. I think that's very commendable, and certainly from an HR standpoint, I very much appreciate employees having an opportunity to ask questions, look under the hood. There's a lot of information we have on the PEBA plan, on our intranet. You can go to the PEBA site, look at the information directly. If you think it's something that we've changed, we have not, but I think they have a tremendous amount, or about all of their information about their plan on their website. So we are committed to being transparent, answering your questions honestly. And I think if you go to our intranet, probably about anything that you're looking for, it will be there in one of the presentations that we did for the Impact Committee. So again, thank everyone for your questions and thank you for attending.